Great. And now go ahead and do a roll call, please.
Yes. Ms. LaFrance.
Here.
Ms. Quinn Davidson.
Here.
Ms. Allard. Mr. Constant.
Carissa, it looks like Miss Allard's here. Maybe she just can't unmute, so you could go ahead and make her present.
Okay. Mr. Dunbar.
Here.
Mr. Rivera. Ms. Zolotel.
Here.
Thank you.
And non-members of the Health Policy Committee, it looks like we have Ms. Kennedy with us as well. And maybe others will join. Okay, well, thanks everyone for joining us today. We're gonna go through a couple things. We'll do a quick update and then move on to 3B and C, which are sort of the meat of our meeting today. Director Harris, are you with us and are you ready to go ahead and do the AHD update?
Yes, I am.
Okay, go ahead, thanks.
Wonderful, thank you. I'm happy to share the great things that are happening here at the Anchorage Health Department. These activities are really focused around what was accomplished in August, given this meeting, and I'll just walk through them. So some highlights around policy recommendations. We're in the process right now of developing a process or a policy statement on adverse childhood experiences, as well as racism as a public health crisis. We are looking at some code revisions, one around animal care or animal control code related to loose animals, and the committee is working on that. As far as public information work, we have really been focused on COVID response and partnering with the EOC. Hopefully you've seen the web page and Facebook page that was launched together Anchorage to provide up-to-date information regarding COVID. So we're closely connected to that work. At the cemetery, the Bell Tower project was completed on July 15th, and that commemorated the 105th anniversary of the cemetery. And grounds preps is getting ready there at the cemetery for the winter. Within the administrative division, again, we have been quite focused on COVID response and providing and responding to questions and providing referrals. We are in the process of diligently recruiting and hiring and orienting 19 new positions related to the COVID public health and homeless public health COVID response, as well as the homeless positions. In grants and contracts, we are partnering with United Way, and United Way is receiving an additional $500,000 to their grant for grant to administer the child care relief funds. As we look at emergency preparedness and circle back around the emergency preparedness work, our Emergency Preparedness Program Manager, Kelly Byastock, became part of the Unified Command at EOC and the COVID response to enhance overall coordination between the Health Department and EOC and to provide a great service for our community. We are very focused on the testing strategy here at the Health Department in coordination with the Emergency Response Center. We have a contract amendment completed with Visit Healthcare to provide expanded test capabilities, which also includes the 6 testing locations, which is comprised of Eagle River and Mountain View as well. We continue to work with Visit Health to test in high risk or high incident locations such as assisted living facilities and municipal operated shelters within Anchorage. And we're working with them in coordination with Alaska State Public Health Lab to coordinate testing or the test to be reviewed here in state, and really looking at just how quick we can get that turnaround time as quickly as possible. We have 12 Anchorage Health Department staff conducting contact tracing and monitoring on a regular basis. And we've been working with the CDC and HUD technical assistance team to review the practices around persons experiencing homelessness during the outbreak. We expand non-congregate sheltering capacities was increased from 30 rooms to 129 rooms in coordination with the EOC Operations Mass Care Branch. And we're also working with the EOC and the state around vaccine distribution and preparing for that when that time comes. We're in bi-weekly meetings with the state and are drafting an anticipated plan to be rolled out. We continue to do daily planning with the EOC around vaccine distribution and continue to work with the EOC logistics team around PPP purchasing. On to Division of Human Services, as we look at the childcare licensing area, the CARES Act funding, which was $10 million for licensed facilities. As of October 1st, 4.5 million had been distributed. And United Way of Anchorage is helping to ensure that every facility that's eligible has the information and is walked through the application process. And at the beginning of the month, all but 8 facilities had applied. As far as licensing updates, we continue to do the regular practice of license updates, and several facilities have either started a new facility, or several locations have started new facilities or renewed their license. One of note is a school age program where Campfire is partnering with the Anchorage School District and United Way of Anchorage to provide learning pods where care providers can be trained and deliver computer technical assistance and schooling supports at Title I schools. So we're excited to see how that progresses. And we're following up on safety mitigation protocols and alternative techniques in supporting those licensed programs as well around COVID. As we look at community, the community safety and development and domestic violence area, almost 4.5 million of the ESG and CDBG funds to address homelessness and services needs related to COVID pandemic were introduced at the last assembly meeting, and we're looking forward to and awaiting the public comment period and hopefully approval at next week's assembly meeting. HUD was also notified on the 2nd of October, the municipality was notified by HUD on the 2nd of October that we have officially of our official third and final CDBG funds in the amount of almost $2 million. And those funds will need eventually to be introduced at the assembly. And I welcome your thoughts or recommendations around where you think we could spend those dollars well. You're welcome to send me an email about that, or we can chat about it. Also in that division, COVID impacts our program manager, Dr. Janet Johnston, was internally promoted to the role of epidemiologist, and we're in the process of replacing her previous position at this time. And we're working through, as I shared before, around hiring those staff related to housing and homelessness service work. As we look at senior and emergency outreach, we continue to provide great service. Referrals and customers are receiving options counseling, and we're continuing to do intakes. And we also, in the senior centers, the service coordinator continues to distribute 40 to 50 meals a day to Chugach View and Manor residents. And that's a door-to-door service, which has replaced the congregate meal setting during COVID. As far as sheltering, we're really focused on looking at decompressing options. And as the Sullivan continues to be at a high number in their facility. Their target is 350, and what we have really seen is that they are serving about 10 to 50 over the 350 individuals in the past few weeks. So decompression of the shelter is a strong focus and conversation in figuring out how to do that well, especially as we go into the winter months. As we look at the public health division, the bulk of our clinic staff continue to be leveraged for the COVID responses. We are continuing to do our TB clinic, and it remains open Monday through Friday with a focus on active TB cases, and we saw 15 active patients in the month of August. The reproductive health clinic continues to be open, but for limited service as well. Our COVID team successfully moved into the CAhoots onto CAhoots system for tracking of cases, and are working with the municipality and the state with a centralized staffing model. As we look at environmental health services, our environmental health services team worked last month with the Bike Anchorage group to host Take a Bike Ride Day in conjunction with World Car Free Day, and that was an exciting event here in Anchorage at the health department. And staff and environmental health continue to work to provide services and to provide permits for temporary vendors and noise permits for construction projects and music events. They are not back to routine inspections, but they have started a virtual inspection process, and they were able to conduct 49 inspections in August. And we've had really great feedback from recipients of that process, feeling like they are a partner and really getting valuable information and making their environments even safer. So as we move on to infants, women, or the WIC program, we continue to provide services remotely and vouchers. And we worked with a consulting firm to identify gaps in services for populations that the WIC program may be failing to reach. So we're really looking at expanding, and would welcome the opportunity to share that anywhere and share that the WIC services for those that are eligible. As we look at SNAP Ed, we ran a social media campaign promoting National Farmers Week in the beginning of August, which had a great reach. And we continue to do social marketing for the many activities that are happening here at the health department and engaging our community, and look forward to doing that even more into the fall. And that's the end of my report. Thank you.
Great, thank you, Ms. Harris. I don't see any questions from members, which you can put in the chat or text me if you prefer. So I'll go ahead and ask one, and then we can move on. You mentioned 19 new positions. Can you speak to what those positions are and what exactly they'll be doing, how we're funding them?
Yes, so those 19 positions are related to the public health nurses to grow our capacity here at the health department to respond to COVID. Contact tracing and monitoring, as well as our homeless positions to build out that work and grow it within the department.
Can you provide a little more detail? What do you mean the homeless positions?
Those are the 5 individuals that will be supporting the work of engaging in with our homeless providers outside of the municipality, and as well as looking at how to best support the future efforts of the municipality around shelter options for persons experiencing homelessness.
Okay, any other questions from members? Okay, great. We'll go ahead and move on. We have a guest here today for 3B. Thank you, Ms. Harris, to present Ms. Stephanie Colston. As you all recall, we appropriated $3 million to begin a mental health first response system here in Anchorage. And a lot of folks have been working on this. Meg and I with Forrest have been engaged in a lot of meetings. I know Mr. Falsey and others. Of course, the core team has also been leading this effort on sort of a smaller scale here. And we're really excited to have a more comprehensive mental health first response system that really pair well with the work that APD does to keep our community safe. So the Assembly, as you probably remember, engaged Ms. Colston, and she's helping us evaluate what sorts of systems make the most sense for Anchorage. So with that, go ahead and get started. Thank you.
Thank you very much. Can everyone hear me all right?
Yes.
Okay.
Oh, it looks like Mr. Constant has joined us, and I also noticed Mr. Rivera is here too. Apologies, Ms. Colston. Go ahead.
That's all right. I've been asked to do a brief overview of some of the models that are out there relating to mental health first, what we call mental health first responders. First, I wanted to just give you a little bit about my background and, you know, kind of who I am and what I've been asked to do. I basically have probably just over 40 years of experience starting at the state level in a mental health system. I was chief of operations for a state system, and that was a valuable experience, but it taught me a lot about systems of care, continua of care, starting with crisis services all the way through. And then I actually ran two different psychiatric facilities, one a hospital and the other a comprehensive community mental health center. And we did have both what I guess you would call today a crisis stabilization unit. We called it the psychiatric intensive care unit. We also had a mobile crisis team. I've spent many years assessing mental health systems and state substance abuse systems, and have kind of gravitated more recently to the substance abuse side as senior advisor to the SAMHSA administrator and White House Office of National Drug Control Policy. So lots of experience in Alaska. I've been working up until about 2 years ago with the state on their 1115 Medicaid waiver, mostly on the design and development of services side. I've also worked with probably 2 or 3 providers directly on sustainability planning and strategic planning. Those were mental health facilities mostly. And then I've worked with the municipality on substance abuse issues, and that's pretty much my Alaska experience. It's been consistent since 2015. I'm here to basically provide independent advice on a mental health first responder kind of program system. And it is not duplicative of Crisis Now. As you all know, I know you've had a lot of presentations regarding Crisis Now, but there are 4 components. Really what I've been asked to do is drill down into one of those components, which is the mobile crisis team. We're calling this the mental health first responder system, or mental health first response. And I'm basically here to provide the Assembly with policy, accountability, model, and financing options for your consideration. And also part of that is it has to be reviewing, you know, the resources that you have in the municipality today. So basically, in my mind, advice means options. What are your options for assigning who's responsible for this system? How many models are out there? And I'm going to briefly talk about those. And there are a number of them, but I want to be sure you understand the landscape out there. Then we'll do a deeper dive. I will bring the information to you about kind of pros and cons for each model, how they're financed, how they're staffed. And then once I do a little bit of a review of what you have, then I will, add that into it. Here's how this might fit with core. Here's how this might fit with something else, so that you understand exactly, as comprehensively as possible, you have the information you need to make a decision. There are some components that already exist in Anchorage, and then the question becomes, how do those fit in with the ultimate design that you're looking for? I've noticed as I've been studying the different models, a good percentage of them are financed by Medicaid. Different types of Medicaid, not necessarily waivers, and I will get into that also for your consideration, because ultimately, I'm sure you're interested in sustainability. In other words, how can we sustain this without depending on the startup monies forever? So that's one of my tasks. My timeline is really between now and December. So I kind of tasked it out in one of the slides on the presentation. I don't know if you have that or not, but work on the accountability and kind of the existing resources in October. Start model design now, which I'm going to put before you right now. Talk about financing probably in November. And then I'll have my final report to you in December, at the end of December. So pretty quick turnaround, and it'll be done. That's all I can say. In terms of a definition of mobile crisis team, mobile services that provide a behavioral health emergency care. That's what a mobile crisis service is. So individuals that are experiencing a behavioral health crisis in the community, mobile services are designed to assist those individuals and get them, do an assessment, triage them, and get them where they need to be, whatever that is. So transportation is a component, a big component actually. And there are a lot of different ways that the transportation is provided depending on the responder model. I have broken down the first responder models, and I think there are, thank you. I think there are two basic categories. One is alternative emergency response models, and the other is what I call co-responder models, and that could be police and a behavioral health clinician. It could be police, fire, EMS, and a behavioral health clinician. So what I'm going to be talking about really now are all of the different types of models that are out there, and there are 23 of them. So I'm not going to go in a great deal of detail at this meeting, but at the next opportunity, I intend to do a pretty deep dive and provide you with how they're financed, how they're staffed, are they 24/7, exactly what they look like, and how they're, most importantly, I think, how they're financed. And a lot of them are financed by, I would say, state funding. Most of them are county-based and local community-based. So there are a lot of different approaches that I think will be very valuable for your consideration. In terms of alternative emergency responses in the models, there are basically three. One is an international model, and it's called the Psychiatric Emergency Response Team. That's the translation, known as PAM in Stockholm, Sweden. That actually is the first mental health ambulance approach that I believe in the world. It's been in existence since 2015. It is staffed by 2 psychiatric nurses and a paramedic, and it is distinct from and separate from law enforcement. So it's an alternative. It is separate from law enforcement. It includes on-site and on-demand, and it's preventative in nature. The second model, and it is not as visible a model, I guess you would say, not as replicated, is called Mental Health First, and that's Sacramento, California. It was developed earlier this year, so it's new. And it basically consists of a hotline and mobile crisis response. This one is staffed entirely by volunteers. There's a crisis intervention specialist, a medic, and a safety liaison. So there are other volunteer models, but this one is usually the models have a combination of volunteer and non-volunteer, or often they do. This is one of the few that is all volunteer. Probably, I know Pam is very, very well known, but the model that's the most well known in the United States is the third model I want to discuss, and that's CAhoots. And that emerged from Eugene and Springfield area, Oregon. It's been in existence for 31 years. It is a mobile crisis intervention team. Literally, they have gone from 1 beat up used van to 4 vans. It is an alternative to for nonviolent crimes, alternative to police response for nonviolent. But it is a part of Eugene's entire emergency communications system. So I think therein lies the link, if you will. It is staffed by either an EMT or a nurse. I think most often it's an EMT, paramedic, and a crisis worker that must have several years of mental health experience. CAhoots has a lot of data, as it has been replicated many, many times and is continuing to be replicated as current events look for these types of alternatives right now. It diverts the public safety workload. It handled in 19, it handled 17% of the Eugene Police Department's calls, 24,000 calls a year. I mentioned 4 crisis vans. Now they're up to 50 employees, and it operates 24/7. And that's important because not all of these models do. It provides immediate stabilization, assessment, information and referral, and advocacy. And based on the last annual report, the city of Eugene an average of $8.5 million a year between 2014 and 2017. CAhoots is being considered in many localities throughout the country, and I actually discovered 2 that I didn't have on the list. In Denver, it's the Support Team Assisted Response, STAR. That is staffed by mental health and substance use disorder professionals. There's a program that has been developed, and I think it has been delayed, just as the Oakland one has, but this one is in Portland, Oregon, and it is called the Portland PSR, Portland Support Response. And it includes a medic and a crisis staff person, but events in Portland have kind of made it difficult for PSR to actually begin operating. So I believe it started and then it stopped. I will get more information about it, but I was looking around yesterday, and it looks like it's still operational. So Austin, Texas has what they call MCOT, Emergency Management Services. No, Expanded Mobile Crisis, I'm sorry, and Outreach Team, EMCOT. That is one of the reasons I think you need to take a look at that model is the financing. They used Medicaid, but when they used it for startup, they used what's called DSRIP funding, which goes away. It's a category that CMS allowed states to use for certain activities. And I believe the MCOT DSRIP funding is going away in the next year or two. So they're going to have to, and this also has a telehealth component. So there are a lot of innovative, I think, pieces of MCOT in Austin, Texas. Olympia, Washington developed a crisis response unit based on the CAhoots model, but it has a little bit of a twist, but it's still at its core is CAhoots model. Oakland, California, and this has been delayed because of COVID, is ready to implement the Mobile Assistance Community Responders system. And that's comprised of mental health counselors with EMTs and police officers. And several other communities you can see on the last bullet have been considering the CAhoots model. And I'm not sure, New York City is pretty close, I think, to making a decision on that. And Albuquerque has a little bit different approach I'm going to talk about in a minute. So it'll be interesting to see how the CAhoots model that they've been thinking about aligns and fits, if you will, with the co-responder model that they have in place now. Senator Wyden from Oregon has actually introduced a CAhoots Act. He did that last month, I believe. And he wants CAhoots to be a national alternative to using police as first responders for mental health crises. I'll tell you a little bit more about that when I do the next presentation, take a little bit deeper dive into that. But I think that's an interesting development. I think it'll be interesting to see how it moves through the legislative process at the federal level. So those three models are the alternatives models. In other words, alternative to usually. So there are two different types of co-responder models. One is law enforcement and a mental health clinician, and there are 10 of those. Milwaukee's CART team is a trained CIT, crisis intervention team, police officer, and a paramedic, and a clinician. It's been here since 2013, so they have, a few years of experience, 7 years of implementing that. And the Milwaukee CART team is based on the Houston, Texas crisis intervention response team, which is very similar. I mean, it looks very similar. It's part of the police department, and it's been in existence since 2008. So long time, several years of responding. It's still going strong, and it's same staffing model. El Paso County, Colorado, that is where Colorado Springs resides, yet this particular Behavioral Health Connect co-responder unit, BCON, is focused on the rural part of the counties. So it is not a Colorado Springs response, it is a rural response. The reason that I think you need to look at that, and probably not too carefully, is the way the staffing is aligned. There are sheriffs, there's EMT, and there are behavioral health clinicians. So, and it's been, I think, they developed that in 2017. So it's still young. It's still early days of implementation. Johnson County, Kansas is where Overland Park resides. And so that's about, almost just under 200,000 in that county. It also, this is an embedded kind of model, where the mental health professional is embedded in the police department. It's been in existence for 10 years. One of the more unique models is Kitsap County, Washington. I don't know if you're familiar with Kitsap. I was not, but it is also an embedded model. Behavioral specialists and what they call navigators to assist police departments. And there are several police departments in Kitsap. It is actually across Puget Sound from Seattle. So it's Bainbridge Island, it's Bremerton. Bremerton is the largest town in Kitsap County, and it is 37,000 people. So this model is diverting individuals who have mental health crises from the criminal justice system and trying to get them into treatment. It's been around since 2019, so it is a very young particular model. Continuing with the law enforcement and mental health clinician co-responder models, DeKalb County, Georgia has a mobile crisis unit, and today that is a suburb of Atlanta. Today it is over 600,000 people. It's been in existence, the mobile crisis unit has, since 1993. And again, this particular one has it is a partnership between the county mental health department and, of course, the county police department. It includes a registered nurse and a police officer. It does not specify that nurse has to be a psychiatric nurse. It just says a registered nurse. Pima County, Arizona is Tucson. And so it's, over 1 million people in the county. And their model began in 2014, and it's just a straight up police officers and mental health professionals. It has a huge prevention focus, as some of these models do. So they're focused on early identification, engagement, and get them to treatment. The Springfield, Missouri is another kind of innovative model, and it was developed in 2016. And it, of course, as you can see, law enforcement will make the first contact, the crisis contact. And if it is a mental health issue, they immediately they have an iPad, and they immediately get the mental health clinician involved, and the mental health clinician then conducts an initial assessment and engages the individual. And if they need to come on site, they will. And they just use their judgment about whether or not they move on and hop in a van and get out there as quickly as they can, or if they believe they can make the referral and do the assessment and stabilize and de-escalate as quickly as possible. Another international model here is from Victoria, Australia, and it is called the Police Ambulance and Clinical Early Response System. And they've been operating this system since 2007. And it's a police and a mental health clinician. It is based on a model I'm going to be talking about in just a minute called the SMART model. And that, I believe, is Los Angeles developed that. So PACER is really, they use ambulances for transportation. They do not use police cars. They do not use, you know, any kind of non-police van, but it is just an ambulance from the, I believe they call Victoria a regional state in Australia. So that's, they have private insurance. I'm not real sure. Private ambulance services that they contract with for the entire region. And it is a fairly large region. So there are 6.7 million people in that particular region. It's a huge, huge region. Then the next slide shows fire department and law enforcement and behavioral health clinician models. There are about 6 of these. The first one is 2014, Colorado Springs, Colorado, and they have a community response team. It's different than the Beacon model that is the county within which Colorado Springs resides. This is just Colorado Springs, and it is fire department, behavioral health clinician, and police department. And the police officer is CIT trained, obviously a paramedic, and they operate 10 hours a day, 7 days a week. So it's not 24/7, it's 10 hours a day. Plymouth County, Massachusetts. This is a little bit different model. It actually was developed in response to the opioid crisis in Massachusetts, and it was developed in 2015. And the reason I included this is it includes 27 police departments and a university and hospitals and providers, and its collaboration and partnership structure includes almost every stakeholder you can think of, and that's why I included that. So basically, the purpose of this model is to de-escalate, obviously, but primarily to get them into treatment. So if there is, there's an overdose, you respond within 48 to 72 hours. You do not go on the site, but it's after. And you assess, you see how they're doing, and you try to connect them with treatment as quickly as possible and seize the moment, if you will. Albuquerque, New Mexico has a COAST system that they developed in 2005. So again, it's been around a while. It is embedded in the police department there, and they have crisis specialists, usually case managers or social workers that go out with the police. They added a psychiatrist in 2007, but they no longer use that particular clinical discipline to respond. I'm guessing because of the cost. Then a little bit different one is the Mental Health Association of Nebraska. The REAL program was developed in 2011, so it's been around a while. It is not 24/7. It is straight up clinical. I mean, it is criminal justice diversion. So, and they use peers to do outreach. So it isn't a typical kind of crisis response, but it certainly has reduced crisis calls by outreach, identifying the individuals before the crisis occurs, and making a referral. and they use peers that have actually gone through the REAL program before. In other words, they've committed a crime, but it's a misdemeanor. They're mentally ill, so they went to treatment instead of moving into the criminal justice system. And the last two are Denver, Colorado's Crisis Intervention Response Unit. And that, Denver has 2.8 million people, so this covers a pretty good size area. And they operate from 10 a.m. to 10 p.m. 7 days a week. So it's not 24/7. It was created by the Denver Police Department department, and that is where it resides. But licensed clinicians go out on any 911 call that they suspect has a mental health component, and they go along with the police officers. And it was developed in 2015. And then PAM, again, it is also fire department, law enforcement, and behavioral health. And I told you a little bit about that, and that is 24/7. So you can see, well, let me talk a little bit about the models in Anchorage that fit into this kind of categorization. I mean, obviously I didn't put generic EMS on this list, but the Anchorage Safety Patrol is, as you know, operated by the fire department. And it has a focus on intoxicated individuals and getting them to the Anchorage Safety Center until they're sober. So pretty, I would say more limited focus, more of a focus on a particular population. The other AFD system is, of course, the core team, and that is paramedics focusing on emergency medical services, high utilizers. The crisis intervention team at APD includes CIT trained police officers. I think that number, as I've been reading, the number has kind of waxed and waned over the years in terms of the number of CIT trained police officers that actually are available to go out on these kinds of crises. Then the mobile intervention team has a focus on the homeless population. So again, 3 out of the 4 Anchorage-based models have kind of a specific population focus, and then the CIT trained police officers just depends on how many are available and how many go out on the crisis. So I would say components, but not a complete system in Anchorage. So bottom line is there are lots of models out there. That I winnowed it down to 23. You have 4 in Anchorage that need to be looked at very deeply to determine whether you might consider how to design services around that model or around that particular capacity. Core team certainly is a possibility. And the next step for me is to do that deeper dive, fully trying to reduce a little bit. I mean, like the Plymouth, Massachusetts comes to mind. Obviously, the scope of this is going to be broader than an opioid overdose. But there were other aspects of the model that were important for you to consider. So I think it would probably be those other aspects that I would focus on for your consideration. So I believe my next step is to do that deeper dive, do the pros and cons, look at the financing, come back with that information. And in the meantime, I will also do an assessment of the 4 Anchorage, just a review of really, I'm more interested in how they're financed. I think I know their features, how they're financed. I need to figure out hours of operation for some of them because it's not clear to me from the materials that I've looked at. And then I'll provide, after we have the discussion about the pros and cons and financing, then I'll be in a better position to provide options for your consideration. Does anyone have any questions or?
Thank you, Ms. Colston. I have a question from Mr. Weddleton, and I also wanted to point out that Jason Lessard is with us as well. He's represents NAMI, the National Alliance on Mental Illness, and he's been working with APD on crisis intervention team training and other items. So if he wants to add anything, but let Mr. Weddleton ask his question.
I can't remember exactly which one, but yeah, they are used.
Okay, great. And we also have the recording going again.
Oh,
Next, Mr. Rivera, go ahead.
Thank you, Madam Chair. I really appreciate this presentation. It was insightful and looking forward to your future work. So I was just curious in the timeline that you provided us. So you are working with us through December, is that correct?
that's correct.
So I noticed in here sort of beginning operations was planned for March. Is that a date that the administration put forward? Or is that?
No, sir. That was just a date that that I believe I discussed with Member Zalatel.
Yeah, we can take that if you want, Ms. Colston.
Yes.
Ms. Zalatel, would you like to speak to that?
Sure. Thank you, Madam Chair. So we wanted to put forward how if we had the options and we were going to look at this in the 2021 budget, either through CARES Act funds, alcohol tax or others, then you know, what could be a potential timeline for turning it on. And so that was all that was just to kind of frame it. There's nothing hard and fast about that.
Great. Are you done, Mr. Rivera? Do you have any follow-ups?
Yeah, I guess just one additional comment. So while I appreciate that as having sort of a date in mind, you know, I think it might be helpful for us come the time when we begin the operations to be able to do some assessments on how things are going, and whether that's through bringing back a consultant or you know, how we do that. I think it's good for us to consider that for when the program begins again. Thanks.
Thank you. Ms. LaFrance, you're next in the queue.
Thank you, Madam Chair. And thank you, Ms. Colson, for all the information and the presentation. The approach is very compelling for so many reasons. And I was interested also in the savings that you highlighted. I think you had pointed out about $8.5 million a year in the city of Eugene as far as diversion. And could you talk a little bit more about potential savings, or even how that's calculated, or anything else, you know, in that approach? And thanks so much.
Usually, and I'm speaking generally because I would like to go back and do some more research before, you know, answering that CAhoots specific question. But generally with these models, the savings are in police time. So particularly a model like CAhoots, where police are able to kind of go back to their traditional public safety function and don't spend all of their time going to a mental health crisis, transporting an individual in crisis to the emergency department, waiting 6 hours for that person to be evaluated, then they're discharged and they go right back, you know, to where they kind of began. And the policeman may see them in another 12, 24 hours. So really that's the primary source of the savings that I've seen with these models. But there are other components, and if it's okay, I would prefer to get back with you if that's all right.
That sounds great. Thanks so much. Thank you, Madam Chair.
Yeah, thank you, Ms. LaFrance. So for Mr. Constant and Ms. Allard, after that, I would like to move on. We're still planning to do a deep dive of the health department budget, and we need to leave time for audience participation. We have just a half an hour left. So with that, Mr. Constant, go ahead.
Yeah, Ms. Colston, just one thing similar to what Ms. Lebo had, a kind of a nuanced detail. The mobile intervention team, I believe, has been at times focused on homelessness issues and at times other issues. And
Okay.
So it might be worth investigating some of the actual application of that
Sure.
team and its function, because while I operated it was to primarily address homelessness. During the early COVID days, they were doing other work, and I'm not sure exactly the nature of the work that they are doing.
Okay. Okay. That's a good point. Thank you. I will.
Great, thank you. Ms. Allard?
Thank you. Ms. Stephanie, I'm calling you Ms. Stephanie. Have we looked at the Juneau homeless model that they've implemented back in 2000? I believe it was 15.
I haven't looked at it, but I certainly can look at it.
I brought some people into the assembly back in June to testify on that, and I would like to be able to get together with you, get those
Sure.
people in, and perhaps make a presentation to the homeless committee, so we could further discuss if you're open to that.
Of course. Sure.
Excellent. Thank you.
Thank you.
Okay. Ms. Allard, would you muting your phone or your computer? I think it's causing an echo. Okay. Mr. Lessard, sorry, I had offered you the opportunity to make a comment and then didn't follow up. Did you want to say anything, or are we good to move on?
Thank you, Madam Chair. I would just echo a lot of the stuff that Ms. Colston had shared. I know that you guys are on a time crunch, so I don't have too much to add right now. I can wait till further meetings and further discussions. I just want to thank you all for allocating the money, for taking up this cause. We can create better outcomes for individuals in need and save money for the municipality at the same time by going in this direction. So thank you very much for your time. I really look forward to working with you all.
I had a question.
Thank you, Mr. Lessard. Go ahead, Dean, and then we really need to move on. And Dean, I think if you could mute after your question, that would be appreciated.
Yes. Can you hear me okay?
Yes, sir.
Very quickly, you were talking about the savings in the 8.5 million in the Colorado County, or the other place. It was on the police costs, and did it show that they reduced police department budgets by that corresponding amount, or was it just that police were the time saved responding to these mental health crises, but police budgeting and costs were the same and used for other emergencies? So were there still an actual corresponding decrease in police department costs and budgets?
Well, I heard about half of that question, but let me see if I can respond to that. I don't know what they did in Eugene, Oregon, in terms of reducing the police budget, for example, by 8.5 million. I do know that the Portland street response is, I believe they are intending to use money from the police department budget to fund that. But I'd rather reserve any kind of factual response to that until I can do a deeper dive on both CAhoots and the Portland street response. Because CAhoots, remember, was developed 31 years ago. So that's a long time ago.
Okay, thank you so
Thank
much.
you.
Dean, can you please mute your microphone?
Yep.
Ah, nice. Okay, so much. And Chris, we'll get Stephanie's email in the chat for you. We'll have to figure out how to navigate having members, she has a certain amount of money that we've divvied up for a certain scope of work. So let's just connect on what other questions members have, because if we need to do additional work, we might have to make some changes. So anyway, great. Thank you everyone for your questions and your engagement. This is really exciting. And yeah, just looking forward to implementing a system that we really need and that probably would save us money. Okay, Ms. Harris or Instead, I don't know who wants to take the lead, but as you all know, we got our budget binders on Friday, or the budget was released on Friday, and we just wanted to take a little time, since there's often interest in the health department budget, and since there could be changes coming up, and of course due to COVID and everything else that's going on, we wanted to have an opportunity to really spend some time on that. So with that, go ahead.
Thank you so much. This is Heather Harris with the Health Department. I am actually going to turn it over to start to Deanne Fetko to walk us through the preliminary part of the deep dive on the budget.
Okay, so I'll go ahead and get started. Hopefully everyone can see our screen here.
We can see it.
Just as a reminder, our purpose here at the Anchorage Health Department is public health, working for all of us all of the time. This really goes hand in hand with our core values surrounding respect, service, and equity for all. Today, again, you'll be hearing from Heather Harris, the director of the health department, and myself, Deanne Fetko. I'm the deputy director here, and I'm responsible for the administration division, and I'm also the budget coordinator for the department. So today we'll be going over just a brief overview of the department, and then talking separately about our 2021 proposed operating budget and the alcohol tax budget, which are listed separately in the budget book. We'll also spend a little bit of time on our 2021 capital budget, and then anything else that folks want to talk about. I think we have about 6 slides to go through here today. Heather talked a lot about what's going on in our programs most recently, but just for those of you who may not be aware, we are an incredibly diverse department here at the Anchorage Health Department. We have 14 distinct programs. We'll just kind of briefly highlight some of the varied and important work that we do here. Our programs range from air quality to the Aging and Disability Resource Center. There they provide unbiased assistance, rental utility assistance, manage the senior center contracts, and so much more. We, of course, as we talked about earlier, manage the Anchorage Safety Patrol and Safety Center contract, animal care and control services. We're responsible for child care licensing in Anchorage. This has been incredibly important for serving parents and families in our community. Our community health nursing program is involved with 3 different areas: infectious disease prevention, control and investigation, which has been definitely highlighted here during our COVID response, as well as reproductive health and health information management. The department is also involved with domestic violence and sexual assault prevention, emergency preparedness, which again right now is so incredibly important for our community response. Our environmental health services team, typically we think of as food safety and sanitation, but they do so much more in terms of responding to noise concerns, mold, marijuana retail, just all of those things that fall under environmental health. Our homeless prevention and affordable housing team is what probably most people think of as our HUD programs. We have a new work group, Housing and Homeless Services, that's coming online, as well as the Women's, Infants, and Children Nutrition Education Program that serves our at-risk populations. Here's just a high-level overview of the health department budget. In 2021, the proposed budget is about 2.4% of the overarching general municipal operating budget. You can kind of see the breakdown here. It's very similar to our 2020 budget in that 53% is funded by tax dollars, another 10% by revenue. We're very heavily grant funded at 37%. This does serve about 116 staffers, as well as 75 staff that are hired through various contracts. One thing that not a lot of people maybe recognize is that half of our operating budget goes directly back out into the community for various grants and contracts, serving the most vulnerable in our community through projects like the Human Services Community Matching Grant, Sexual Assault Response Team, Domestic Violence, also senior centers, animal control, the Anchorage Safety Patrol, and that just names a few. So getting into the proposed 2021 operating budget, there's no changing to staffing levels under this budget. It does increase contractual obligations for some of our services, including animal care and control and cemetery maintenance. We worked really hard this year to do our RFPs and invitations to bid in advance of the budget process, so we would know what those services were going to cost. It also includes $200,000 for the Brother Francis shelter. There's a couple of transfers and decreases. The proposal moves the Anchorage Memorial Park Cemetery to the Parks and Recreation Department, and holds executive and non-rep pay scales flat from 2020. Okay, now here's the new part to the budget for 2021, the proposed alcohol tax budget for the health department. There are staffing increases of approximately 1.8 million under this budget, and you can see the breakdown of those different positions. There's an epidemiologist that is focused on infectious disease response and investigation, as well as responding to trends and outbreaks, very heavily involved in COVID right now, and that will shift as we do wrap up COVID to continuing to serve the entire community and focus on vulnerable populations. There are 11 full-time positions slated for community health nursing, program manager, public health nurses, and family service aides. Their focus will be on moving through COVID and then into primary prevention and surveillance activities. Our homeless team is 5 positions, and you can see those listed there, a program manager, as well as coordinators, an office associate, and support staff for managing finances and contracts. There's $44,000 in the budget for the Anchorage Domestic Violence and Sexual Assault Intervention Program, otherwise known as ADVSAIP. That funds partially an APD officer and part of a Department of Law clerk. It also brings 3 of our partners that we work with under that project back to their 2019 funding levels. Those partners under that program are Awake, Victims for Justice, and STAR. There's $30,000 in the budget under supplies. When we're bringing on this number of staff, we do need supplies and equipment to support those positions. And then in the budget as well, there's $6.16 million for contractual and other services. Some of these projects I think we've presented on in the past. They include some homeless projects for overnight shelter of 150 individuals, as well as operational costs for shelter, daycare center, or treatment center. There's $1 million for early education grants to providers. I believe this is for seeding high quality universal pre-K. Evidence-based grants to providers in the amount of $1 million for to prevent and reduce the impact of adverse childhood experiences. I think we've been talking about this quite a bit through the alcohol tax presentations and meetings. And then there's 1.8 million for pay for success. We haven't really had an opportunity to determine what all that involves. Okay, we're moving on to the 2021 proposed capital budget. There's for the Anchorage Health Department facility. Yes.
I'm going to stop you there and we have some questions, and I'm just going to ask the members if they want those answered now rather than going into the capital budget, since they're likely on the operating budget.
Okay, sure.
Ms. Eltel, did you want to go ahead?
Sure, thank you. Actually, that last slide was what my question was out of. So I want to express a concern, and then I have a question. The homelessness positions, as I've seen some of those job descriptions, I just wanted to flag that I really feel like a lot of that, or a portion of that, is duplicative excuse me, of the work that the Anchorage Coalition to End Homelessness is doing. I appreciate embedding some of this work in the municipality, but I want us to make sure we're leveraging with community-based resources. The other is the operational costs for shelter, day center, and/or treatment center. Is that number meant to be all inclusive? Because we did have a commitment from philanthropy for day shelter, and so I just wanted to get a better sense of that particular number to know if it was inclusive or exclusive.
Go ahead, Heather.
Maybe I'll speak for a moment to the first question, just around the homelessness positions and potentially being duplicative of the homeless coalition. I think that as we continue to just develop this work within the health department, now and in the past, we have been in deep collaboration with the coalition and really see the value of the work and the importance of the hat that they wear specifically in the community, in coordinating and connecting and advocating. And so we really look forward to continuing that deep collaboration with the coalition and ensuring there isn't duplication, but increased synergy and support for the work that's going to happen here at the health department as well as with the coalition. So I appreciate that feedback and look forward to more communication and connection about that and how we can really work together well into the future.
I'm not sure we can really answer the second question at this point. We're still diving into the budget as proposed, but we could certainly get back with you on that question regarding the 2 million operational costs for shelter.
Great. Thanks.
Great, thank you.
Thanks, Deanne. Is that it for you, Meg? I'll move on to.
It is, thank you.
Go ahead, Chris.
Thank you. So from this slide, it appears that the administration is proposing $8 million to the health department for alcohol tax spending. Is that a simple, accurate assessment of what this slide is saying?
Yes.
And so I thought we just authorized a lending program for Pay for Success. So what is it that we are using those dollars for there?
We are still pretty preliminarily jumping into this and getting the details. I don't know if Bill or Lance are on the call that can answer that in more depth.
Yeah, this is Bill Falsey, the municipal manager. Sorry, I'm doing multiple things here, but you're right, Assemblymember Constant to the chair. We authorized a lending program, but there isn't a source of repaying that loan. So this Pay for Success entry is kind of a pass-through to probably eliminate the need for actually using that sort of line of credit off of the KeyBank master lease, as I understand it.
So we're willing to do less with the alcohol tax money. Okay, that's definitely an area we should be discussing. Thank you. I'll hold questions more on that for now.
Thanks, Mr. Constant. And I agree too. It looks like according to this, about 2/3 of the alcohol tax money would be spent on homelessness related items. Anyway, any other questions? Okay, go ahead and carry on, Deanne. Thank you.
Thank you. On our 2021 capital budget, we have for the health department facilities some immediate system and safety needs in the amount of $2.5 million. That includes some heating system issues, as well as some safety and security needs. The Anchorage Memorial Park Cemetery, even though that is moving to Parks and Rec, you know, it's been in our department so long, it's left in this particular presentation. $350,000 for facilities, fencing, and ground improvements. Both Anchorage senior centers have a number of projects ranging from $300,000 to $350,000, depending on the senior center. They're mostly related to systems issues, code upgrades, and renovations that are necessary for those facilities. And then there is $70,000 in the capital budget for the kennel flooring replacement at Animal Care and Control. Just because many of you have asked, what are some other priorities that the health department has that aren't necessarily able to be in this budget or provided in this budget? There is a need for administrative support personnel, specifically in the public health division, which is our largest division in the department. There is on the second bullet there, it speaks to nursing and nurse supervisor competitive pay. The nurses at the Anchorage Health Department are paid lower than other nursing positions, either at the state or at the Anchorage School District, other areas in town. We're currently in the process of doing a pay study, but wanted to highlight that as a need that's coming forward in the amount of about $490,000. Program and policy administration is another area of need. We seek to have support for forwarding our accreditation with the Public Health Accreditation Board to be a highly functioning local health department. This would also provide for prevention activities and special projects. We're just really lacking in capacity in that area. I think this one has been brought up at this committee before, or one of the assembly committees, the Anchorage Safety Center Safety Patrol contract. There's a need for funding for leave for that contract. That was not one that went out for RFP or invitation to bid this year, as it's a continuation contract in the coming year. And then one thing we really haven't been able to assess since the budget just came out is the resources that may be needed for the implementation of the $6.16 million contractual items under the alcohol tax, including that pay for success line. That was our last slide. Are there any other questions?
I have a question from Mr. Dunbar.
Thank you, Madam Chair. And, while you were speaking, I opened up my health department tab on my operating budget binder. And the way I do my budget review is I sort of save the operations budget for last. I go through the other two, which I'm in the middle of doing. So I admit to have not read this in detail. And so for someone like Bill or Jason, if they are on the phone, perhaps there is a tab that succinctly lays out the plans for the alcohol tax. But if you were to read the health department tab, and again, I admit to not have gone through it in detail yet, but it's not at all clear that the very large increase in spending sort of managed by the health department regarding the alcohol tax is there. I'm just saying it's hard to sort of see that. So what's the plan for how you're going to present that? And I realize mostly that's because it's contractual rather than direct increased costs to the health department. But what's the plan to present that, and not just for the health department, I suppose, but also for all alcohol tax related spending?
This is Jason Bockenstedt, and I'll take the first crack at this, and if I get it wrong, Lance can jump in. But through the chair, Assembly Member Dunbar, we were requested multiple times by a large majority of the Assembly to separate the alcohol tax out from the general operating budget, and that is what we did. So if you look at, I believe it is Appendix R, that is where you will find all of the detailed discussion on the actual alcohol tax and where we are proposing the funding from that goes.
Great. Okay, thank you. Yeah, I admit I haven't fully read through the operating budget binder yet. And so for Chris, it's the general government operating budget. Apparently it's Appendix R. So everyone should probably keep a close eye on that one. Thanks.
Mr. Constant, did you get your question answered?
Well, I had to run and grab my binder, but probably.
Okay, let us know if you need anything. Any other questions? We only have 5 minutes left. I'd like to leave some time for audience participation. So if there are no other questions, we'll go ahead and move on. Great. Next section of the agenda is section 4. We don't have anything to report on 4A, legislative priorities, and on 4B, of course, you just saw the budget items for 2021. So I think we'll go ahead and move on to item 5. Is there anyone who would like to give audience participation?
Hello, can you hear me?
Yes, Mr. Haberman, go ahead.
I'll be extremely brief. This is Eugene Haberman. There were a couple of presentations you had today from the health department specifically. The public did not have the availability of those documents. You were going through those particular slides. The public could not see it. If you check the community website scenario where your committee is, there is a presentation, but that was the second one of the 3 that was presented today. So this is becoming an ongoing situation, and what concerns me particularly is we're going into the budget for next year, and you're seeing financial matters of the city, and you're having that conversation among yourselves with the public not seeing those papers. So that concludes my remarks, and I wish you all the best.
Thanks so much, Mr. Haberman. Is there any other member of the public who would like to give testimony? Okay, not any final comments or questions since we have a few more minutes before we adjourn. Okay. We'll see you all in a few minutes at the Public Safety Committee. Thanks so much. This meeting's adjourned.